2006, CDC issued guidelines promoting routine screening for HIV among people aged 13 to 64 in all healthcare settings. These guidelines stress that early identification of HIV infection prevents unnecessary additional infections and lowers the lifetime cost of care significantly. It didn't take long at all before CDC declared this to be the most widely disregarded guideline they had ever issued. In 2008, Harris Health System received CDC expanded testing grant funds through the City of Houston's Department of Health and Human Services and began working to find a cost-effective method of HIV screening that would not interrupt the workflow in our busy emergency centers. How do we go about designing the program? We used a broad-based steering committee of EC physician leaders, nursing, lab, the IT guys, legal, corporate communications, which proved to be very helpful, senior hospital administrators, and the medical director of our HIV clinic. 2, we focused our efforts on 4 program components. First was informed consent. A separate consent for HIV testing is not required in Texas. The language in our general consent was deemed sufficient. In addition, we developed an opt-out form which explained HIV testing and provided instructions for opting out of the test. Signage in English and Spanish was posted at registration desk, phlebotomy stations, and in the EC waiting area. Second was testing technology, and what proved to be a major innovation and provided the foundation for our program's success. Our lab director determined that finger stick or cheek swab testing was not feasible in busy ECs like ours. He maintained that we could just draw an extra tube of blood for each patient having blood drawn for other purposes and process those samples on a continual basis. Using this approach, we have results in less than 2 hours, and few patients are out of our emergency centers in less than 2 hours. Third was data management. The needs for data in a routine testing program can seem endless, but by including our IT staff from the beginning, we laid essential groundwork for efficient test ordering processes, quality management of the program, and reporting results to our funders. And finally was linkage to care. Without linkage to care, an HIV testing program cannot be truly effective. We're fortunate that our organization includes one of the largest HIV clinics in the country, the Thomas Street Health Center. So we assigned service linkage workers from there to work full-time in each hospital EC, providing test results to patients, educating them and their families about the importance of timely HIV care, and initiating the process of linking them to clinical care. These service linkage workers also help patients address barriers to care, such as lack of transportation or housing. And finally, what were our results? We started testing in the Bentob Emergency Center in 2008 and expanded to LBJ early in 2009. Since then, Project Rush has grown to encompass 13 of Harris Health System's ambulatory care clinics, as well as its Healthcare for the Homeless program. We have performed more than 500,000 tests and identified 1,180 new cases of HIV, with lab cost of only about $7 per test. In addition to these new infections, we've identified about twice as many previously diagnosed individuals, many of whom were out of care. Having this opportunity to interact with these patients has proven effective at relinking them to care, an unanticipated benefit of our program. By using a mathematical model from the CDC, we've calculated that Project Rush has prevented more than 240 new HIV infections and saved the healthcare system more than $90 million in lifetime cost of care, far more than our cost of operating the program. What have we learned? That using a widely representative steering group to design our program helped to ensure broad support. Planning for data management needs before the program launches is essential. Linkage to care must be a part of a successful HIV screening program. And finally, especially in a large, complex healthcare system, assigning one person key responsibility for program implementation rather than expecting a busy doctor or nurse in the emergency room to do it in their spare time, is critical.